Hi everyone, this is Counseling 4000, Chapter 17, using the DSM. The Diagnostic and Statistical Manual of Mental Disorders is also known as the DSM, and we are on the 5th version at the moment. Collection of diagnoses of mental disorders accompanied by the typical behaviors and symptoms you might see in particular diagnoses. So again, it tells you the name of the disease or the disability or whatever it is, and then it also tells you all the different possible symptoms, and also, what are the things that you might see when it comes to this person having this type of disability. Okay. Provide a common set of criteria for each mental disorder. Professionals are more likely to give the same diagnosis to people with similar symptoms, and familiarity with the language and process of the DSM helps you plan competently. So what that is basically saying is that we're hoping that if everyone knows like the exact same characteristics, if you give like 5 different people the same client and they observe it, they should all diagnose that person with the same type of disability or disorder. Okay, that's what we're hoping the DSM is going to help you with. There's a quick reference of the diagnostic criteria from DSM-5 as well that you can purchase if you don't want to buy the entire book. Is DSM only a mental health tool? So when you do an intake, for example, for a woman at a domestic violence shelter, you might also find out that she also has bipolar disorder and she's also addicted to heroin. The DSM is the language of insurance companies and other funding sources with regard to behavioral treatment. Such things as alcohol treatment, treatment for those with mental health problems or addiction issues, and then of course intellectual disabilities as well. You may realize that the person may not qualify for a mental disorder, but requires attention in a clinical setting because of this. You need to know the DSM so you can make appropriate referrals if necessary for your client. There are also cautions when it comes to the DSM and for new people who are human service providers, okay? Most people who come in for services in social service agencies are not suffering from a mental disorder, okay? Every client does not need to have a mental disorder to receive services. There are such things as life transitions, such as loss of work, grief from the death of a loved one. Those things are more likely of reasons why people are going to come in. Not that they have schizophrenia or bipolar disorder, because these are transitional things. Let's say maybe a divorce, something like that might be an issue more than anything else. And that's not really a mental health disorder, right? It will make people look or feel sicker than they really are if you try to diagnose them during this time period when they really don't have those things. It's because they're just trying to deal with, transitional life problems that we have. The DSM is a medical model. It labels you as having an illness, and we treat you like a person who is sick. In counseling, we see it through a holistic perspective where your diagnosis is part of you and you have strengths and successes. So from a counseling perspective, it's not everything. We don't necessarily need to fix it, but we need to work on it, okay, and address it, know that it is there. Be cautious about diagnoses that do not seem to take into account what might be typical for people at a particular culture. Again, so here's an example. A lot of people tend to say that Asian people are very quiet, and then they don't necessarily speak up for themselves or make comments in class and stuff like that. You don't want to necessarily say, oh, this person doesn't ever talk, so they're antisocial. It might not be because culturally they're not raised or expected to talk to adults or professionals or question their authority or anything like that because it's considered disrespectful. So it's a cultural thing. It's not because they're antisocial and don't want to talk to anyone. Who makes this diagnosis? A physician can make a diagnosis or a senior staff person, usually with a PhD. But for some insurance companies, a diagnosis is required during intake to provide kind of like a provisional diagnosis, which means kind of like the initial one. Then the diagnosis may be changed by a senior staff person later on. Okay. Also, depending on your training, you with a master's can also do it as well. Background information. Until the 1600s, physicians used a client's or patient's horoscope to diagnose mental disorders. Medieval physicians used 4 humors for differences in human personality and temperament. So back in the olden days, this is literally really old, like medieval times, with knights and stuff like that, they usually said that there are 4 parts of a person's kind of like personality or body parts. And one of them is blood, which is happy temperament, which is like a happy, good person. Choler is a fiery or like a feisty or argumentative type of temperament. Phlegm is kind of like mucus-y stuff. So they're cold and they have a delicate, they're sensitive, they're overtly sensitive temperament. And then bile is basically kind of like part of your body, and it also means sadness in you, okay? So they might say you have a lot of blood or a lot of choler or phlegm or bile, and that's how they usually kind of diagnose you with the disability or the current issues that you have. Oh, that person has just too much choler in them. Psychiatry attempts to classify mental disorders. So during colonial times, most people with mental illness were at home with their families. Okay, many were abused and exploited or taken advantage of. Harsh treatment in almhouses, which are basically kind of like a institution back in the olden days. In the 1800s to 1860s, Dorothea Dix wanted more humane and respect for people with illnesses. So she was a huge person in the field of rehab or disability that you guys should be aware of. Moral treatments in federal asylums failed, so she worked with specific hospitals to help make it a little bit more humane and kind and respectful. In the 1840s, people were either sane or insane. Shift from asylum to treatment happened in the late 1800s and early 1900s. So it's only been about, a little bit over 100, 120 years or so, 30 years, 40 years, 140 years, when people started understanding the brain and diagnoses were refined. Believe it or not, a lot of people didn't really understand how the mind worked. And so it took a while before all of this would get together where we would say, hey, let's treat people with disabilities with kindness and respect as well. In the 1880s, there are 7 types of mental disorders that were classified. Emil Kraepelin looked at syndromes and symptoms through the course of disease and the outcome. So basically this person looked and then started to list things so that there was going to be something that people can observe or reference to. Adolf Meyer saw mental illness as a psychosocial stressors, so military breakdown under stress. So there's certain things that happen in the military that would cause, let's say, mental illness like depression or shock or PTSD and stuff like that. So that person saw more of a what's going on in society, and when things are too stressful, it might cause certain things, right? But now it's seen more as a discrete psychiatric disease. So what that means is instead of blaming someone or a situation, it's really just depending on the person, okay? The 1940s, there are 10 types of psychosis, 9 neuroses, and 7 disorders related to behavior, intelligence, and character. And around that time, in 1952, the first edition of the DSM became. You can see that people started to learn how to kind of like put things in a list, right? And relate things to each other. And that is all the foundation to when the first DSM was created by the APA in 1952. In the 1950s, 60s, and 70s, the manual was still quite unreliable. Again, just because something is written out and published doesn't mean that it's the end-all, be-all, the final thing. No, there are a lot of mistakes still because people are still trying to understand mental illness, which is invisible, right? Psychiatrists would give different diagnoses to the same symptoms. So that means different trained psychiatrists would see one person but then diagnose it as this thing or diagnose it as that thing, while another person would diagnose it differently. If they're using one book and they're all interpreting it in different ways, that means that book really is not reliable, right? Because everyone's on a different diagnosis, so then that doesn't really help. Replication for research is impossible then because of that also, because it's not dependable. People started to not take mental health as seriously. Insurance cut back on treatments because there was no consensus of best treatment. And usually with insurance, they'll say, if cognitive behavioral therapy is really effective, we want you to use that, then they're going to use it. But because it was just so undependable at that time period when it comes to diagnosis, they're going to go, no, we're not going to help this person. Psychiatry becomes more medical in the 1980s, relied more on a medical research-oriented model of disease. So research becomes really important because when more and more people are researching and they're finding out commonalities because there's a lot of people doing the research and they're saying the results are similar, that's good. That helps us then to understand specific disabilities much more easily, because if a bunch of professionals are doing it and they all agree, that means that most likely it's much more accurate, right? right? But if we had just a couple of people do it and they're all different on all over the place, it's not necessarily very easy to understand or trust worthy. So then there would be difficult ways to try to treat a person with a specific disability. 14 discrete and specific mental disorders with very explicit descriptions. So they're saying there's 14 different types, and it's basically strictly on what you can see. And being observable is something that's really important when it comes to research, right? Because we don't want to just do theoretical stuff that doesn't necessarily can be proven. We're looking at things that we can see, we can understand, we can diagnose because we physically see those behaviors or whatever it is. 1. There was every attempt to use clear English and not mental health specific jargon. 2. Disorders were labeled and not people. 3. Patients was dropped in favor of words like person or individual. So instead of saying patient, you want to say this individual had this behavior or this individual or person displayed this behavior. 4. The manual was tested for reliability for the first time by clinicians using it in the field. So again, they said, use this book and learn from it the descriptions of, let's say, what schizophrenia is. And when you go into the real world and you meet people, you can just see by their behaviors or the symptoms that they all have schizophrenia. That means that's good if everyone is diagnosing the correct thing or everyone is diagnosing one specific person with the same thing. That means that this is becoming more helpful and easy to understand. 5, a multi-axis system was adopted to give a further diagnostic picture of the person. So instead of just one thing, we're going to approach it in 5 different ways and see how we can help this person and understand this person. 6, decision trees were included to help the physician rule out similar disorders and narrow the diagnostic choice to one. So what that basically is saying is maybe there is some symptoms that are very similar to another disability. We want to see when they split between those two and how do you go to this one as opposed to that one. Okay. 7, the word disease and illness was dropped in favor of the word disorder. 8, all the pet theories about causes of disorders were eliminated. Those are kind of like the minor theories of why things were happening. We don't want to use those anymore. We're going to use hard, basically research from professionals in the field and use that and rely on that instead of just like theoretical things that people were sort of maybe thinking about. Instead, we're just saying let's prove it and then just use those things instead. 9, each order had a working definition that contained operational criteria. That means criteria that could be observed and measured. Okay, so the only way that we trust it is if we can actually see it and observe it, and then we can count on that. But if it's something where it's theoretical or in the assumptions, we don't want to make those assumptions always because those assumptions can be very wrong. Far more likely to make the same diagnosis for the same set of symptoms. If everyone saw the same symptoms, they could try different interventions to see the results and adopt the best practices. So let's say that we find a diagnosis for autism, and then one set of doctors are going to help them this way with specific type of treatment A, and then another group of doctors will work with them and then use treatment B. Then we're going to do the research and see what the results were, and let's say that treatment B was much more effective, then we're going to start adopting that one. Okay, that's what it's saying. Okay, from DSM-3 to the DSM-5, we move from a monoetic diagnosis to a polyethic diagnosis. So let's define what that means. A monoetic diagnosis is unless all series of symptoms that were constituted a disorder were present, you could not use that diagnosis. A polyethic diagnosis means a series of symptoms is given and the person must have several but not all of them. Okay, before it's like if you don't have all these, you don't have this. But now they're saying if you have some of it, you could potentially still have it because depending on the person who is unique, there might be certain reasons why they didn't display specific types of symptoms. Reliability of diagnosis improved because of this, and also now people could be diagnosed with more than one disorder at the same time. Before it was just choosing the most important one. Okay, because people can have bipolar disorder and obsessive compulsive disorder, let's say, right? Before it was like, let's just focus on the bipolar disorder only. All right, matched up with the International Classification of Disease, or the ICD, for an international conversation. So that's something that's really important because we in America use the DSM, the rest of the world uses an ICD, model, and so we need to be able to match them up so that we can get along with other people in different countries and really understand what's going on when it comes to mental health as well. They also removed sexist language in the DSM-4, so things that are not necessarily appropriate, they've reconsidered, they've made it so that it's gender neutral and not so sexist. The DSM-4 TR, TR stands for text revision. Basically, what happens is that you refine the diagnostic category still further and brought new information to the diagnosis. So basically, the fourth edition is out, but we want to fix a couple of things in there. So then they did the TR version because it's not ready for a whole new book, which is like the fifth one. They revised it, and actually we used the text revision 4 version for a very long time, actually. So number one, every disorder has a name, numerical code, the criteria needed to give the diagnosis, the subtypes of the disorder, the specifiers, recording procedures, and examples that illustrate the disorder. So all those things are now included in there. 2, associated features and associated disorders may include such items as clinical features that may be present but are not always seen in the disorder, disorders that precede, often co-occur, or generally follow the disorder in question, and typical laboratory findings, physical signs and symptoms, and typical medical conditions. So what that is basically saying is that sometimes a disability that you diagnose them with will have something that happened before or during or after that is often common. Let's say HIV and then pneumonia, okay, or something like that. 3, the typical age of onset and any cultural and gender-related information is now included. 4, the prevalence of the disorder, the incidence and the risk. So how often does it happen? And what are some of the risks that happen with it? And then, of course, why is it happening? 5, a description of the typical clinical course of the disorder. So to understand when a person is diagnosed all the way to the end of their death, what are some of the common things that happen? 6, the typical predisposing factors discovered through research. So some of the things that might pop up because of research that describe that mental illness or whatever it is in more specific detail. 7, the family patterns in if there were genetic or specified genetic or suspected genetic components to the disease. So is it something that you can get from your parents, or is it something that happens because something happened, something else happened? Where is it coming from? And then of course 8 is differential diagnosis or disorders that share similar symptoms and information on how to distinguish among similar disorders. So if there's something that are really close or related, how do we tell the difference between this one or that one when you're making that diagnosis and then working with that person? The transition from the DSM-4 TR to the DSM-5 happened in 2013, so that is the most recent one. It will take some time for insurance companies to adapt, so you may still see DSM-4 TR diagnosis on the client's charts and forms. So if you do have a DSM-4 text revision book, which you probably spent a lot of money on if you bought it before the DSM-5 came out, now it's probably like $1. However, it's really important to still have that because some of the cases that you work with might have been diagnosed with the DSM-4 TR. So if it is, by having it, you can actually refer to it and see exactly how they were diagnosing them, what was the wording, what are the symptoms and stuff, because the fifth one will be different than the fourth one. DSM-5 is the current diagnostic manual. It's written for clinicians and not necessarily for case managers, but don't freak out, you can still use it. They have similar disorders are in adjacent chapters, which means that they're next to each other if they're similar. The course and development of a particular disorder so that you can see how it differs as people age. So that one is kind of seeing it in a lifespan. If a child is born with autism, what happens to the rest of their lives? They kind of let you know what they believe is going to be maybe specific characteristics and stuff like that. When appropriate, look at gender and cultural issues that could affect the diagnosis as well. Obviously, there are some disabilities or diagnoses that are female only or male only. Some are both. So all those things, maybe it is a specific culture that is more likely to have it than another one for whatever reason. Those things are going to be talked about here so that you also understand that the differences in multiculturalism. Number one, the DSM-5 looks at genetics and neuroimaging. So they see, how does it occur? Does it come from your parents or your family? Is it a cultural thing as well? 2, online supplemental information to help clinicians make accurate diagnosis. So now there's a website version of it as well to help them along with the book. 3, World Health Organization or WHO Disability Assessment Schedule 2.0, also known as the WHODOS 2.0. Self-administered survey to give a better picture of how well the person is functioning with a severity scale for scoring. And that's just to see tracking improvements. If they were at this number, are they at a better number or are they at a worse number? And we want to know because we want to see how they're doing as you're going through, let's say, an intervention, helping them improve their condition, let's say. 4, a symptom severity chart for psychosis, allowing a person to define better the degree of psychosis and how severe the symptoms are for that person. So again, how bad is it? You know, we want to rate it and understand where is it going. And then 5, the ICD numerical codes are included to bring diagnosis into line internationally. So they'll also put the ICD codes there so that we know what the equivalent is in the ICD book. You will be asked whether the onset is in the past or recent, in partial or full remission, described as mild, moderate, severe, or extreme. So these are ways that they will let you know how bad or good or weak or strong something is, the intensity of it, okay? And also remission, is it not happening even though that person has it? It's not doing anything, not affecting anything? Or is it impartial? Is it sometimes doing it? Or is it, fully effective? The severity of the disorder, the degree to which the disorder interferes with a person's ability to function. Not all diagnoses will ask you to specify the severity. So because some of them don't need that, but some of them do. So example, it would be anorexia, body mass index BMI. The lower the BMI, the more severe the disorder. Okay, there's a range in the body mass index. You can look in your health books or go and Google it. And the lower numbers means that this person is very, very thin. And that's not necessarily very good for that person. Bulimia, the number of compensatory episodes a person has in a week. So how often do they do this? The self-induced vomiting 1 to 3 times a week would be considered mild, but if they did 14 or more episodes a week, that would be considered extreme. So you would also have, the numbers to gauge so you can find out what the client, when they say that they are inducing vomiting and they do it once a week, we would label that as mild, okay? Specifiers that apply. So enuresis is urinating into clothing or bedding. So we need to specify, is it only at night, which is nocturnal? Diurnal, which basically means during the day only, or is it nocturnal and diurnal, which means it happens both during the day and at night? So that's something that we would need to know when it comes to this specific type of disorder. There's also persistent depressive disorder. Specify if the person experiences emotional distress. And there's a list of stuff in the DSM-5 that you can refer to. So it could be partial or it could be full remission, which means that it's not happening at all. There's also early onset, which is before 21 years old, or later onset, which is after 21 years old. So these are information that you would need to label and categorize when it comes to your client. Pure dystrophic disorder syndrome is other forms of depression, such as major depressive disorder or intermittent major depressive disorder, is something that you need to specify, and all of that stuff is told to you in the DSM-5. Okay, multiple diagnosis. Most prominent and most in need of relief would be listed first, and then the others are listed in the order of importance. Okay, so obviously, what is the major issues? What are the major problems? That would be listed first, and then you would, list all the other ones as you see, and then we want to address the most severe first. Other conditions that may be focus of clinical attention. In the back of the DSM is a section titled Other Conditions That May Be of Focus for Clinical Attention. Problems people have without having a psychiatric disorder, and distress is a normal reaction to what is going on in their lives. So let's say that a person is freaking out because of a death, right, of a loved one. That's normal. If you love someone and they die all of a sudden, you should freak out a little bit. It's no okay reaction. It's a normal reaction. So we're not going to say this person is, has, schizophrenia or anything like that. It's really about understanding, is it a typical response that people usually have for something that happens, okay? They're also known as V codes. Such examples would be relationship problems. Let's say if they broke up with someone and they're very depressed. Usually that happens, right? Abuse and neglected issues, domestic violence, and work and income troubles. There may be a combination of disorders with a V code, which allows a case manager to know that the V code may affect the disorder. So again, one might affect the other. Getting fired might make a person who's depressed even more depressed. Does that make sense? So knowing the V code helps them, as the case manager, the therapist, or whatever, understand what's going on. If they're taking medication and there is a side effect of it, let's say that the side effect is gaining weight, right? Then that might be something that is also going to cause that depression to get worse, or whatever it is. When the diagnosis does not quite fit, some people may describe their symptoms, and those symptoms sound a lot like depression, but the person's symptoms do not meet any of the criteria for the disorder listed in the chapter on depressive disorder. So basically, even though they sound like they're sad, but they're not actually meeting any of the qualifications for it, then it might be something else, right? So in each chapter, you will find at the end of a section that gives you other choices. Something as other specified disorders, or OSD, or unspecified disorders. See if it fits into those areas. Use when we know the symptoms belong to a certain category of disorders, but the person does not entirely meet the criteria for any of them at this time. Okay, so they might have it, but we don't really know why, or they just don't have enough of it just yet to really qualify them for a full diagnosis. When there is no number, sometimes you will find a diagnosis in the DSM-5 that has no number. That would be major depressive disorder has no number, asking you for more specific information such as, is this a single episode, does it only happen once, or is it something that's happening all the time? First time that this happened, depressed or other occasions, is it mild, moderate, or severe? Are there any psychotic features to it? And then also, is there partial remission, full remission, current episode unspecified? All those things are something that you need more information so that you can really understand it. And then those will have numbers.